So we've heard about analytical specifications, we've heard about pre-analytical specifications, and I'm going to talk about post-analytical specifications. This is the building that I've spent most of my working life in, and I was rather proud of living and working in a building that was 150 years old, but clearly I have to recalibrate myself after coming here. So what I'm going to talk about is essentially about diagnosis, how we help with diagnosis, and whether we're doing the right thing or not. So if we think how diagnostic tests, I'll leave out the Lundberg brain-to-brain loop, and we'll just take the doctor choosing a diagnostic test. And how on earth does he or she choose the test they're going to use? They use experience, and they use guidelines. And they put those results together, they choose their test, and they come up with a result. And then we step in and potentially interfere. And there are two ways that we can interfere in the post-analytical step. One is by doing reflexive tests, and these are essentially automated tests that are organized in advance, and they're triggered by our computer systems rather than necessarily having any human intervention. And then secondly, we have reflective tests, which are sometimes called narrative testing, where a scientist looks at the results and says, actually, I can help you out a little bit here by doing something else. And so that's really the area I want to look at. This is really an issue only for clinical chemistry and hematology. If you send a sample to a histopathologist, if you send him a colon cancer to a histopathologist, he doesn't send you a photograph back of what the histology looks like. He interprets it for you. If you send a sample to a microbiologist, you expect the microbiologist to do the culture and then to do the sensitivities, and may even actually ring you up go to the ward and say, this is the right antibiotic to use, it's against all the standards and guidelines, but this is what I would recommend. There's no question that histopathologists and microbiologists take that intervention, but there is a question, I think, as to whether clinical chemistry and hematology should be taking that role. So that's really what I would like to explore today. So reflexive testing, just as a reminder, is automated addition of extra tests, and reflective testing is this manual interpretation, this individualized interpretation and addition of extra tests. And these are a few examples. So if someone's cholesterol is high, we'd add on an LDL. Perhaps if triglycerides are high, you do a direct because we can't estimate LDL. For those people who do TSHs alone, we would add on a free T4, quantitating HCG, doing the cascade test for hepatitis, and perhaps even adding a free PSA for somebody with a modestly elevated PSA. So this is what, when I started in my life, someone would go along to outpatients, they'd have a blood sample taken, they'd get these first-line tests done, they'd then come back a second time, they'd have a second blood sample taken a few weeks later, then they'd have a third sample taken a few weeks later, and the whole process took a long, long time. And what we're hoping to do by automating it is to speed up that process. I have a slight concern as to whether that's the right thing to do or not, because what happens is that in the old days, we worked out what the sensitivity and the specificity of tests were depending on what the clinical scenario is. And when you have one test result, it changes the clinical scenario, and we don't necessarily know what the sensitivity and specificity is if we throw all the results together as a single pattern. And that was a problem that really arose when we started doing SMACs 40, 35 years ago, when we were doing results that weren't necessarily done in the right order from the diagnostic point of view. So reflective testing is the human intervention. It's about establishing a diagnosis. It's about assisting in patient management. It's about reducing time to diagnosis. It's key, I think, is about reducing the number of samples because that speeds up the whole process. And potentially it reduces the cost because it removes the additional cost of patients coming to have venipuncture and actually the cost of venipuncture. These are all assumptions on our behalf. There is no evidence whatsoever to show that any of these things are true. We assume they're true, we'll all swear blind they're true, but I'm not sure there's any evidence to support that. It's very much based on clinical judgment and the knowledge and experience of the clinical scientist who's doing it. And in these days of evidence-based medicine, we're trying to move away from anecdotes of, oh, I remember 20 years ago a circumstance like this arose. And there are issues about ethics. So when I first started, in fact, where most of us first started in clinical chemistry, if we thought somebody was pregnant, we'd add on a pregnancy test, or if we thought someone had a high acid phosphatase, you might add on a PSA. Whereas that sort of thing is probably frowned upon nowadays because it leads to a sort of diagnosis that the patient may not want to have, and the doctor may not have actually negotiated with the patient about doing those sort of diagnostic tests. So there's advice, I'm not going to bore you with these, there's advice from the Royal College of Pathologists saying that we can add on tests as long as, and I think the key point there is that bottom line, it says the investigation is in the best interest of the patient. And we've had advice from the General Medical Council that say, again, we can do it if the test is in the right clinical area and we're behaving properly. And I understand from our American colleagues, the reason why this isn't allowed in America is because 30 years ago there were some dishonest pathologists who were adding on really expensive tests onto simple tests and just boosting their income by doing it. So it was legislated against. So let's come back to this diagnostic process. That's my sort of introduction. And let's have a look at what the evidence is for all these steps. So the evidence for experience for doctors, whether they can actually choose the right test. We'd look at the evidence of whether the guidelines are correct or not, or what the guidelines are based on. And then the evidence for reflexive testing and for reflective testing. So, can clinicians choose the right test? I'm obviously speaking to a very well-prepared audience because all of you will say, no, they can't choose the right test. Well, this is an interesting little clip that was on the BBC News. It appeared after a medical student in Sheffield working with Trevor Gray asked junior doctors whether they felt confident requesting and interpreting tests. And these were brand new housemen who were just in their first 6 months of being qualified and working on the wards. And of course they weren't certain about doing the tests. And medical schools don't teach very much about testing strategies. So unfortunately it was converted from a very young junior doctor to being a rather senior elderly doctor who didn't know how to interpret tests. So that's a rather a light-hearted approach. But let's think what the American Society for Pathology have done. They've got this organization called Choosing Wisely, where they give recommendations about which tests should be done and which shouldn't be done. We shouldn't be doing vitamin D testing, we know that. We shouldn't be doing free PSAs until we've decided whether or not someone's got a modestly elevated PSA. So there are 40 tests they've now got, 40 bits of advice they're giving. So they've already decided publicly that doctors are not very good at choosing tests. And that's their website if you want to pull off the PDF with all the 40 different tests on it. And this is probably one of the best bit of outcome research that's ever been done, I think, in clinical chemistry, which is done by Tony Fryer in Stoke in North England, where he looked at how well HbA1c testing was being done in terms of outcome, in terms of costs of drugs, in terms of outcomes, in terms of renal failure, amputations, and visits to hospital. And they realized that people who did badly didn't get tested very regularly, and people who were tested phenomenally frequently, like 10 or 12 times a year, probably didn't do very well either. And clearly the ones who were tested 10 or 12 times a year were sick. They were in hospital all the time, and they were being investigated by lots of people, so they did the test time and time again. And people who turn up to have their HbA1c done once every 2 or 3 years are not looking after themselves, and they don't do very well either. But one of the key things that Tony Fryer's group have done is they've shown... So I've just lost my train of thought just for a second. Yeah, I'm going to have to forget that. That just slipped by me. But there's really good outcome data there for frequency of testing and how often they should be being done. So let's move on from how well doctors are doing to how well they can interpret tests. This was a systematic review of how well doctors could interpret tests. And you won't be surprised to know that they don't know very much about tests. They don't understand accuracy, they don't understand Bayesian reasoning, and they don't understand what the terms specificity and sensitivity mean. So it comes back essentially to the question I asked slightly earlier on of Matthias, of whether the doctors actually want to know, is the result 49 or is it 50? Because that's as far as they understand. And so the grey scale, I think, is going to be quite difficult because they can't come up, they don't understand grey scales. I sometimes think we don't understand grey scales either, but that's another matter. And so there's not an awful lot of literature on what is the effect of misinterpretation. I don't know what your hospitals run on, but one of the hospitals I work in demands that every woman under the age of 60 has an HCG test before she has an intervention performed. And so I, every 3 months or so, get phoned up by a surgeon saying that our tests are wrong because I've got a pregnancy test that's positive in a 59-year-old woman who's had a hysterectomy. And every now and again there's a case report saying that there is HCG produced by the pituitary in normal postmenopausal women. And then many years ago, Rick Jones of blessed memory and I wrote up about a case in the BMJ of a patient who had innumerable investigations for ascites because someone had measured their CA125. And so this poor woman had had scans, she'd had a laparotomy looking for her ovarian cancer before someone had the wisdom to measure her thyroid function tests and found that she had ascites due to hypothyroidism. So there clearly are real problems with misinterpretation of laboratory tests, but I'm not sure that we're very good at documenting them. So how about guidelines advocating tests? I don't expect you to be able to read this slide. This was in the BMJ about a month ago, and it looked at all the guidelines for diabetes that are and what their recommendations are. And you can see they've looked at HbA1c, glucose, EGFR, urine albumin creatinine ratio, and hemoglobin. And that's the evidence for it. And you can see there isn't any evidence for any of those tests in diabetes. Right? It's all run on consensus. And even the recommendation that HbA1c should be measured every 2 to 4 months, which is the top recommendation, is based on consensus as well. There's no outcome evidence for any of these guidelines. So there was another study, which was in the BMJ Open a couple of years ago, in which the authors spoke to the people who did the systematic reviews for the guideline tests. And these were their comments. So they managed to get a cohort of 17 or 18 people of professional guideline writers and guideline studiers to try and work out what the answer is. So they found that, first of all, there was a problem actually developing the question that they were supposed to be asking, which was interesting. The PICO, which we all use for evidence-based medicine, that's patients, intervention, comparison, and outcome, was not suitable for diagnosis. The data was all confused, i.e. it was poor quality. We all know there's no budget for doing diagnostic tests, so there aren't very many diagnostic studies. The harms, resources, patient preference haven't been looked at. Physician education, we know how much we teach our medical students in our own hospitals about diagnostics, which is pretty much close to zero. And the worst thing about it was the panels who were involved in signing off the guidelines didn't know what sensitivity and specificity meant either. So it means that we've got a real problem, I think, in terms of trying to get the concept of guidelines and diagnosis and some sort of science built into it. And then, so we're looking essentially at opinion rather than evidence. And this is such a problem that, again, the BMJ's had to publish guidelines on how you tell the difference between opinion and evidence. Evidence is actually something where you've got some facts in front of you. And opinion is where people say, this is what I think. It's not rocket science, but it's not rocket science for us, but it clearly is rocket science, but difficult for people in the BMJ. And so these were articles in BMJ and Lancet talking about the problem. So I mentioned opinion and evidence. We've got transparent data collection. That's what evidence-based medicine is all about. And then we have a problem that the EFLM Guidelines Committee has been struggling over for quite a long time, and this is this concept of conflicts of interest. And we all understand financial conflicts of interest, but the one that's a real problem is intellectual conflicts of interest, and people don't like to admit that they're wrong. So I'll skip along because we're getting a bit late. So good guidelines are good if there's really good guidelines, and this guy Jack O'Sullivan in Oxford has done a lot of really good work on guidelines. And they've looked at guidelines, they've looked at the quality of the evidence, they've looked at, So they've looked at the quality of the evidence, and then they've looked at large GP databases to see whether or not people use those guidelines in the way that they investigate patients. And they found that the guidelines which have got poor quality data inside them are not adopted and are not used by clinicians, and the ones with high quality data are adopted and used. So, reflexive testing. So reflexive testing, as I've said before, means that you take one blood sample and you cascade tests on it so that you get the maximum use of that blood sample and you speed up the whole process so it all gets done in 1/2 afternoon. So it's a great idea and it speeds everything up. There's not a lot of evidence for or against it, apart from the fact that we believe it's the right thing to do and patients don't like having too many blood samples taken. In America, there are really strong regulations about what they can do, and the big American pathology websites say that on their reflexive testing strategies that unless you specifically say you don't want this done, it will be done. And they've all had agreements with all their clinicians to say that their clinicians are happy for it to be done. So that's not true in the UK. I'm not quite sure about the rest of Europe, but in the UK, we can add on those extra tests without necessarily getting formal written agreements. So the value of it is about speeding things up. And these are some questions that I'd quite like to ask you, and I don't know the answers. Do clinicians notice test results that they've not requested themselves? Do they act on the results? Do we know what the sensitivity and specificity is when we don't know what the pre-odds ratios are? And the problem with adding on tests is you produce many, many more false positives than false negatives. And what are the problems with those false positives? And I've already highlighted the case report of the patient with ascites due to hypothyroidism as being a false positive. So now let's have a think about reflexive testing, which is essentially what Ian Watson asked me to speak about. I've just said she put the context all in. So reflective testing is what we do when we add on, and that'll differ from junior scientists to senior scientists. It'll be around case-based discussions with clinicians as to what they want us to do and how we adapt, what protocols we've got, what guidelines there are. These are all things that go through our mind when we look at results and say, well, I'll add on an extra test here, or I'll put a bit of narrative comment on the bottom. So there are several options we can go down. We can go down an appropriate test adding on and we get the right answer. We can miss out an appropriate test and we've got a lost opportunity for making a diagnosis. Or we can have an inappropriate test leading to an abnormal result and producing this dreadful thing called Ulysses syndrome, is where you start chasing wild goose chase. You've got a wild goose chase looking for something that isn't there because you've had a false positive or a false negative result. No one's quantified how often the Ulysses syndrome occurs, but I suspect in this ever so litigious world that we live in that it happens quite a lot. I just hope it doesn't happen to me one day. So how good are we at our narrative comments and our add-on tests? So it's a bit like asking turkeys to vote for Christmas, really, isn't it? If you send out a survey to your doctors and say, do you think I'm doing a good job? You're only going to report it if they get good answers. And these are 4 studies that have been done commenting on how well doctors like our comments. But they're very small studies, and they've all had very poor return rates. We're talking about 30% return rates on some studies that are as big as 60 or as small as 60 or 70 invitations. So I'm not entirely sure that this is evidence that I would be particularly proud of to say supports our practice. What's slightly worrying are the EQA programs that have been done looking at narrative reporting on blood test results. And this is data from Sam Vaisikaran's group in Australia. And you can see that these are the results are generally good, but there were some that were inappropriate, misleading, or in a few instances dangerous. And then in a second paper, he talks about incorrect or misleading interpretation and advice. And so we can't go around really encouraging everybody to be doing this if we haven't got our own house in order. So there are harms of us adding tests. First of all, we don't have informed consent for it. If we start doing biopsies and things like that, obviously there are physical harms attached. The chances are if we add on a test, it's not going to give a diagnostic answer anyway, so we're going to create even more uncertainty. There are added extra costs, which are I suppose, trivial in the cost of an annual budget of our laboratories. And then we have the problem of incidental findings, the Ulysses syndrome. And that's an issue, really, isn't it? Because there's a lot of discussion nowadays about overdiagnosis, particularly in prostate cancer, breast cancer, and monoclonal bands in serum. So all testing produces a degree of overdiagnosis, and we need to make sure that if we're going to get involved in adding extra tests on, that we don't make this whole idea of overdiagnosis a greater problem than it actually is. And I've mentioned already about adding uncertainty by adding extra tests. So is there any evidence from outcome studies that it makes a difference? So Eric Kilpatrick did probably the only really clean bit of data research on this. He moved into to Hull in about 2000, and prior to that, nobody commented on any thyroid function tests at all. So he started testing people's commenting on thyroid function tests, and he reported that what happened was that the number of patients whose thyroxine replacement meant their TSH was in the right report band increased with time. So clearly his intervention made some effect. There's another good study looking at the interpretation of lipid profiles and identifying patients with familial hypercholesterolemia and them getting treatment. And then we've had reflective tests looking at for hemochromatosis. And hemochromatosis is another good example of overdiagnosis, because the number of patients who've got hemochromatosis who actually get to trouble with their disease is fairly small. There's very little research about diagnostic uncertainty and outcome, and in particular, there's very little research that's done in real time looking at diagnosis uncertainty. And there's the systematic review, the one that I've cited here, looked only at half a dozen papers, so the outcome of that is largely difficult to interpret. But I would argue that what we should be doing as a profession, if we're going to be doing reflective and narrative reporting, is that we should be doing some research to find out what the outcome of that is in terms of causing uncertainty or speeding up diagnoses. So, reflective testing, is it the right thing to do? First of all, it's accepted dogma. We all think it is the right thing to do, but we don't know the outcome. We don't know how our actions interfere with clinical decision-making. The evidence for what we do is poor, and we need to do more research. And my real concern about this whole area is the quality of some of our colleagues. Thank you very much.